Hello, welcome back. This is Professor Young, and this is part one of two at our look at the final piece of the skeletal system, which is joints. Uh, we've spent a lot of time on the skeletal system. There's a lot of complexity within that skeletal system. And while the overall structure of the skeletal system isn't complex, how it works to be complex. And so that is where we are right now. We are beginning to look at how exactly how exactly bones articulate with one another. And really, when two or more joints come together to form an articulation, that is what we are defining as a joint. It's exactly where we are. And so these next two WIMBA sessions are going to be specifically dealing with the articulations that occur within a joint. And so with that said, why don't we go and jump into this? This slide here just has some basic terminology for us. We're going to define here what a joint is or what an articulation is. And really that's any point where two or more bones are going to meet and form some kind of movable connection, right, between them. And keep in mind that there are different types of joints that we're going to be looking at. There's four major classes that we will get to here in a couple minutes. Now, the study of joint structure and function is called arthrology. And when we look at how joints move, it's not enough to just kind of consider the bone structure itself. I mean, all right, we've got two or more bones. They're intersecting. They're forming some kind of movable intersection between them. What's holding that joint together are ligaments. We know that ligaments are made up of dense, regular connective tissue. Because the force and the stresses that are applied onto that tissue are all within the same direction. We understand all of that. But bones by themselves cannot move. Bones rely on muscles to contract, which are going to pull the bones to force the movement. And so it's not enough to really just kind of look at the joint structure. And that's where kinesiology comes into play at. Kinesiology is the study of the muscular skeletal system. It's all about how the body moves, how it goes ahead and gets from point A to point B. What are the forces that are involved? What are the stresses that are involved? Which direction does force move in? What impact does friction have? What impact does heat have? What impact does momentum have? And we could keep going with that. But kinesiology, takes that study of arthrology to the next level. Yes, we've got bone, but bone alone doesn't cut it. There's additional movement that takes place. And that additional movement that happens with the bone happens because of contraction within the skeletal system. And so the two, in that case there, needs to be studied side by side. When we consider naming a joint, what we need to take into consideration here are the bones that are making up the joint. And so as an example, the atlanto-occipital joint is composed of two bones, the occipital bone and the atlas, or C1, cervical 1, of the spine. Specifically, the articulation point that happens between the occipital bone and C1, cervical 1, takes place between the occipital condyles that are on either side of the foramen magnum and the superior articular facets that are associated with the atlas. And so what ends up happening is the occipital condyles are concave, so they're in that type of a shape, and they articulate with the superior articular facets that are associated with the atlas. And that's what allows your head to move up and down, front to back. It's almost like a rocking chair. The occipital condyles kind of rock back and forth within the superior articular facets. And so again, we use the names of the bones to make up the joints. Right? The glenohumeral joint is another one of those joints, right, where we have the head of the humerus of the upper arm that connects or articulates with the glenoid cavity associated with the end of the scapula. And so if you go back and you remember with your bones, that glenoid cavity or glenoid fossa is convex. It dips in, it forms a cup. And the head of the humerus ties in with that, and we refer to that as a ball and socket type of joint. The ball of the humerus fits into the socket associated with the scapula. In this case, that would be the glenoid cavity or glenoid fossa. Same thing with the radio-ulnar joint. Right? Here's a joint that is established between the radius and the ulna of the lower arm. And it's considered a joint because those bones are connected. They are connected through connective tissue, dense, regular connective tissue. And the radius and the ulna pivot around each other. In fact, the radius twists around the ulna. Right? And so if you hold your hand palm up, remember your radius here is lined up with the thumb. The ulna is lined up with the pinky. And when you twist your arm, when you twist your hand so that now you're palm down and everything else has stayed in normal position, the radius needs to twist over the ulna. And so there is an articulation that happens there. And so that is why we refer to that as a joint. And so each of these three joints here represents a different type of joint. And there are 4 different joints overall that we need to consider. The first of them is going to be the bony joints. And then we need to consider something referred to as a fibrous joint. Then going into a cartilaginous joint. And ending our discussion here with synovial joints. In this particular WIMBA session, we are going to be focused on bony joints, fibrous joints, and cartilaginous joints. We're going to save synovial joints because it's a little bit more larger of a section for the next WIMBA session. The other thing that I want to make very clear about with these types of joints, not all joints start out and finish the same type. And typically we see this being very common with both the fibrous joints and the cartilaginous joints. Very often, fibrous joints and cartilaginous joints, over time, as a person ages, will transform and become a bony joint later on in life. Think of, think of the soft spot on the top of a baby's head. The cranial plates, the cranial bones, have not completely solidified themselves. There's still a lot of cartilage that's in between all of them. And so, or it's just, it's a fibrous joint, but it's basically cartilage. There's still a lot of fibrous material that's between those cranial sutures. And as that infant gets a little bit bigger, that suture is then replaced more and more with bone, and eventually it does ossify completely and solidify completely. And so that's some things that we need to take into consideration as we move forward and we start looking at the joints, is that there is a possibility that they will switch the type of classification that they are as a person ages. And so with that said, let's start our look at here and our discussion here with the bony joints. All right. Now this here is a immovable joint. This is key in our understanding of what a bony joint is. I know we said earlier that joints are movable, that they articulate with one another. In this case here, an immovable joint doesn't do that. Right? It does not do that. And what happens with this, what leads to this, is ossification. The fibrous connective tissue or the dense connective tissue that is found making up that joint ossifies, and it makes it immovable. Right? Clear example, if you look at the frontal bone of an infant and you compare that frontal bone of an infant to the frontal bone of an adult, you will notice that the frontal bone of an infant has an additional suture that divides the frontal bone. And that is clearly and evidently absent from the adult. And so that would be an example of a bony joint. The frontal bone is a bony joint. You can't even tell in the adult, but if you look at an infant's skull and that frontal bone, you will clearly see that at one point in time there was a joint there. It completely ossifies over. Cranial sutures tend to completely ossify by the time you are in your 60s and 70s. And so again, we classify them originally as a fibrous joint. They end up being a bony joint as that person ages. And the third example here that I'm going to use is the attachment of the first rib to the sternum. As a person ages, once again, the fibrous joint tends to ossify, which is why it becomes so much easier for someone to break one of those first couple ribs, because of that ossification that tends to occur specifically within the first rib. Keep in mind, fibrous joints and cartilage joints allows for some movability. It allows that joint to be flexible. There's give to it. And so part of the reason for that is because we don't want the bone to break. And so if we allow it to be flexible at some point in time, instead of just being this rigid piece of bone that's rigidly connected to another piece of bone, by giving it some elasticity and movability, some free range, you prevent it from breaking. And so elderly people have a lot more of those joints that have ossified over, which makes, and as we've already learned, not only do they have that ossification that's occurring, but remember they tend to lose bone density as well, especially within females. And so now you've got less flexibility and you have an increase in bone brittleness. And that's a recipe for disaster. Fibrous joints. This is type 2 of our joints that we need to consider. And what we see with a fibrous joint is a connection between two bones that relies on collagen fibers. It relies relies on that collagen to go ahead and form a connection. Now, there are 3 types of fibrous joints. We have sutures, we have Gumphoses, and we have Syndesmosis right there. Right, 1, 2, and 3. And we're going to take a look at each of those three here coming up on the next few slides. Even though there are three types, let me be very clear. What connects these three types of joints is the fact that they are held together by using these collagen fibers. Sutures are the first one. And so if we take an up-close and personal look at a suture, this would be in an adult, we can see that what is actually holding together the cranial plates, in this case here, the parietal bones, the right and left parietal bones, it is definitely the presence of that collagen fibers. And you can see that there. Now, it's those collagen fibers that as a person ages, the collagen does not get replaced with collagen. Instead, it ossifies. And so this here is just one example of what we're talking about here. And there's some variations on this that we'll talk about as well as we get a little bit further in depth into this. And so the second type of fiber strength that we have are Gumphoses. This here is basically a collagen fiber that helps to anchor the tooth within the mandible. All right? And so within the mandible, you've got a bunch of sockets if we're talking about the lower, the maxilla if we're talking about the upper teeth, but I'm going to focus on the mandible here. And that tooth fits down into that socket. Now, think about the reasoning why we would want to have an articulation point with collagen, basically forming that joint within teeth. Why don't we just want the teeth cemented in place, especially once you get your adult teeth? All right, we can understand maybe having some kind of fibrous joint in order to anchor in baby teeth because you're going to lose them anyway. But why do we maintain that same structure when we go ahead and we become an adult? Well, the answer is simple. And it goes back to what happens whenever we form a bony joint. If you lose that ability to be flexible, when you put stress and pressure on that joint, you increase the chance of breaking a bone. And one of the things that we don't want to do is walk around breaking teeth. It's not advantageous for us for our survival. And so by going ahead and having what is basically referred to as a periodontal ligament, by having this periodontal ligament, which is fibrous, which means that ligament is made up of cartilage, by having that, we give that tooth a little bit of wiggle room. And so when you bite down on a hard pretzel, or when you tear into a piece of steak, or when you're eating your ear of corn, or when you're snacking on peanuts or chips, or biting into a piece of really good, hard, dark chocolate, your teeth aren't going to break in place because they're allowed to wiggle a little bit. Yeah, you ever been in a fight and get punched in the jaw, and a tooth loosens, and within the next day or so, that tooth tightens back up again? The reason for that is because what you've done is you've loosened the ligament, and then over time, over the next 24 to 48 hours, that ligament tightens back up again. And so it's critical for the function of chewing that we have elasticity. We have a little bit of give within the jaw, within the teeth specifically. Now, what ends up happening when you lose a tooth, let's say your baby teeth, what ends up going on here is the periodontal ligaments are basically cut. They kind of detach themselves from the tooth. And then the next thing that happens is the root of the tooth kind of dissolves. And that's why when you lose a tooth, you're only really losing that top portion of the tooth. That's why you never really see the roots, because they've dissolved, and once they dissolve, the periodontal ligaments loosen up, and it releases that tooth. And those ligaments will stay loose until that new tooth comes into place, at which point in time it'll reestablish a connection with that tooth, with the adult tooth, and begin to tighten up and hold that tooth in place. So again, here so this is all about flexibility. You don't want certain bones to be rigidly in place because they don't respond well to stress. Now, the third type of fibrous joint, syndesmosis, is what we see within or between the radius and the ulna. We also see it with the tibia and the fibula. Right? And again, it is a fibrous joint, as you can see right here. It's a fibrous joint that is formed between those two bones, and it allows for rotation. It allows for rotation. It gives those two bones a little bit more stability. It gives it a little bit more structure, and it allows for rotation, and only a certain amount of rotation, and that's critical. You don't want to hyperextend, or you don't want to over rotate anything, because then you can actually start causing damage to the bone. And so those ligaments there, these fibrous joints, again, it's all about boundaries. It allows for some rotation, it allows for some movement, but it puts a limit on that. Told you this stuff was, this here is fairly simple stuff. Can you identify it? Do you know what it is? Can you give me an example? You're good to go. All right, and so far we've talked about bony joints. So far we've talked about fibrous joints. We understand that in some instances, such as sutures, fibrous joints can become bony joints. And what we want to do is we want to look at the third of four joints here, and this is a cartilaginous joint. And again, this is an articulation between two or more bones, but now we're not talking about a fibrous connection with collagen. What we're now referring to here, or talking about here, is a connection between two bones involving cartilage. And we have two types of cartilaginous joints. We have synchondrosis and symphysis. And what we want to do is kind of spend a couple minutes looking at both of these types. And then we're going to introduce, or be introduced, into the fourth joint. And then starting in the next session, we'll go into detail about that other joint there. And so, with our first type of cartilaginous joint, synchondrosis, or synchondroses, as it's sometimes pronounced, here we see the root word chondro. Right? And right away, chondro, as we already know, links back to and means cartilage. Right there. And so a synchondrosis is going to be a joint that where the bones are held together specifically by hyaline cartilage. Right? And the best example we have of a synchondrosis type of joint, a cartilage-based joint, is the epiphyseal plate, right? Or that growth plate that is found at the ends of long bones, and it's found at the ends of the vertebrae, right there. We know that this is a temporary joint. We know this is a joint that is going to ossify in and around the person's late teenage years, early 20s. And again, the other area here, and this is another one that's a prime example for becoming a bony joint, and that's where the first rib attaches into the sternum. And so there's your examples of synchondrosis as far as a cartilaginous joint, your epiphyseal plate and where your first rib attaches to the sternum. The big takeaway here for this, and I don't know how many times I can stress this, is that these joints very commonly become bony joints. All right? Very, very, very common for these guys to become bony joints. Very, very, very common. And so don't lose sight of that. When we talk about symphyses, as far as a cartilaginous joint, we can turn our attention to one of two areas. I'm going to have you focus on one area over the other area. The pubis symphysis is one area that is a cartilaginous joint. We know that there is that piece of cartilage that joins the right and the left part of the pubis of the hip bone together. Right? You can see that joint right down here, right there. Right? That is a cartilaginous joint, and it's there for a reason. It allows for flexibility. It allows for some movement within the pelvis. It reduces rigidity, which means that, especially if you're a female, you don't break your hip during the delivery process, during the birthing process. That would be bad. That is not something that we want to have happen. And so that pubis symphysis allows for flexibility within the joint. The other place where I think it's kind of critical that we have flexibility is within the vertebrae. And what allows the vertebrae to maintain some flexibility is those intervertebral discs. It's the cushioning pads that are found between each vertebrae. We know as a person ages that these intervertebral discs tend to wear out, or people that have back injuries or very poor posture, what they end up developing are bulging discs, where the discs become out of place and get squeezed and popped to one side or the other between the vertebrae, and that is very painful. It causes inflammation. It causes fluid buildup, and if caught early enough, it can be fixed. Through manipulation, it can be fixed. It can be repaired. The problem is if it's left to go untreated for so long and it becomes a severe issue, very often what ends up happening is those intervertebral discs begin to degenerate and wear down. And then you've got degenerative disc disease. And typically what they do to treat that is they can't go in and put a brand new disc in. What they typically do is they fuse the vertebrae. And so that way you reduce the movement between those bones, which means you don't have the grinding. Now, does it reduce the pain? In some cases it does. Does it lessen the severity of the pain? Yeah, definitely. All right, but the other thing it does is it also reduces the ability to move, because now you fused 1, 2, 3, or 4 vertebrae together, and so you lose that point of flexion that the intervertebral discs were there for. All right. Our fourth type of joint that we need to consider is a synovial joint. Synovial joints are unique and different because whereas everything else has been a solid connection, bony joint, it's a solid joint between two bones. That's where two bones are connected by more bone. With a fibrous joint, it's a solid connection where collagen fibers integrate themselves and literally force themselves into each other bone to form a lasting connection. In a cartilaginous joint, cartilage forms a solid joint, a solid connection. But in the synovial joint, we actually have a space that is developed. The joints are actually separated, or the bones are actually separated by a space, what we call a synovial cavity or a joint cavity. And you can see that right here. Right? You can see that there is a space. Here is, and these are fingers here. This here would be the metacarpal, right there, and this here would be the phalange, right there. And so you can see that space between the metacarpal and the phalange, there is a space between those two bones that are located there. What this does, and this is kind of a unique construction feature of the body, synovial joints allows for very smooth, almost like an ice skater gliding over a sheet of ice, if you would. It allows for a very smooth articulation between the bones, where really the bones never touch, because there's that space that is between them. And what ends up happening is pressure builds up within that joint, which releases a tiny film of fluid from right there and right there. That fluid is what we refer to as being a synovial fluid. And it's that synovial fluid that gives it that very smooth, gliding appearance of the two bones in question. Most of the joints in our body fall into this category of a synovial joint. And again, in the next WIMBA session, that is what we're going to be spending a good deal of time looking at, identifying these joints. So let's talk about the general anatomy of a synovial joint. We have hyaline cartilage that caps the ends of each of the bones. This is what we refer to very often as articular cartilage. Right there. It is made up of, I cannot stress this again or enough, hyaline cartilage. Right there. All right. If we go back to the previous slide, right, we can see this here is the articular cartilage. Bad placement of the arrow. There's the articular cartilage right there. There's the articular cartilage right there. Right? And so you can see that grayish blue area is the articular cartilage. If you go out and get yourself an order of chicken wings, barbecue wings preferably, or like mild or hot wings, and as you're chewing off all the meat and everything like that, you get to the ends of the wing bones, and you'll notice that there is cartilage. It's hyaline cartilage that's on the end of them, and that again allows for that smooth articulation. It is from the articular cartilage that synovial fluid will be released. Right? And so then we have the synovial cavity or articular cavity, and I pointed that out on the previous picture as well. And again, the synovial fluid is released from that articular cartilage that is the end cap of each of the bones that are involved in making up the joint. All right? Now, the synovial fluid, it does a couple things. Because it's rich in albumin, it's high in protein, and so that allows for the shine that you see, or the smoothness that you see within that area. The hyaluronic acid is what's going to help remove waste material. As well as provide some nourishment. The protein base, the albumin, is going to provide nourishment as well. And again, it reduces the friction. If you want a joint to move smoothly, reduce friction. What causes mobility issues with people that maybe likely need a hip placement? Right? What ends up happening is the head of the femur that is now inside or inserted within the acetabulum of the hip. Well, you've got hyaline cartilage, you've got that articular cartilage that's covering the head of the femur. You've got articular cartilage that is lining inside of the acetabulum. And as the hip moves, again, it's moving frictiously or freely because of the synovial fluid that's being released from within the articular cartilage. When that articular cartilage is damaged and breaks down and it's no longer there, what you do is you've got bone rubbing against bone. Well, bone is porous, and as it rubs against each other, it creates a great deal of friction. And that friction causes heat, and the heat distorts and wears down, deteriorates the bone. And that's where the pain comes from. And that's what you try to avoid. And then you've got the articular capsule. And again, if you go back into the learning module for this, or the PowerPoint, you can see that it's very clearly defined for you within there. The only other thing I will go ahead and point out is the presence of a structure known as the meniscus. Now, the meniscus is an extension of the capsule. The meniscus is an extension of the capsule. It is only associated with the knee. Right, so the knee is an example of a synovial joint. It's a hinge joint, and it has this extension of the capsule that kind of goes, of the joint capsule that kind of goes into the cavity, extends into the cavity. And so if we look here, this is the capsule. This is the capsule. And we can see that area right there, this area right there, that would be defined as the meniscus. And I'm going to remove those little red dots for you. All right, that would be referred to as the meniscus. And what that meniscus does is it just provides a little bit more tension on the joint. It provides a little bit more, and this was in the knee, I should say. You would see this go in a little bit further. This is a finger joint, so we don't really have the meniscus in there. But this would definitely come in a little bit deeper if that was the knee picture there. And what happens is it just firms up and tightens up the joint a little bit more, gives it a little bit more pressure, a little bit more force, and allows that joint to function a little bit more free-flowing, if you would. And so again, what would end up happening here is this would be a even further exaggeration, if you would. That would come in like that. This would come in like that. All right, so it's even a greater intrusion into the cavity, all right, that the capsule takes. And so that's your introduction to joints. As I mentioned already, the next WIMA session is going to have you look at synovial joints specifically. There are 6 different types of synovial joints that you're going to be responsible to identify. And then after we get into that, after we go through that, we're going to spend some time talking about specific movements of joints and show you a couple pictures of arthritis and all that kind of happy-go-lucky stuff. And so with that said, I will leave you guys to review this material. If you have any questions, again, please do not hesitate to shoot me an email, and I'll see you guys around the corner. Thanks.